طيب خلاص. بسم الله الرحمن الرحيم. سامعني؟ سامع محمد؟ Good evening, everybody. On behalf of City Eye Center, I would like to thank the Jordanian Ophthalmology Society and Orchidia Pharmaceuticals for joining us in our webinars in City Eye Center. Our first speaker will be Dr. Muhammad Bilal Khalil. He is a glaucoma specialist. Dr. Bilal finished his undergraduate in University of Jordan Medical School. He then joined the residency program in Eye Specialty Hospital, had his fellowship in Eye and Ear Infirmary in New York, and then he joined City Eye Center and many distinguished centers and hospitals in Jordan and abroad. Please, Dr. Muhammad Bilal, you can start your presentation. Muhammad, there is no voice. ثواني.
Good evening, everybody. This is the City Eye Center webinar starting today with part 1, the glaucoma part. Tomorrow will be the neuro-ophthalmology part. So I'm sharing my slides here. Okay. So our topic today is the structure-function correlation and some updates from the new devices that we are using in everyday practice in glaucoma. So we will have a little introduction and then we will make it a case-like presentation, multiple cases, and then we will have some 10 minutes, 5 minutes for questions. So the first poll I would like to introduce it to you is the definition of glaucoma. The cornerstone in the definition of glaucoma is, and you can start answering now. We will have like 20 seconds, please. Okay, can we see the results, please? So 60% said it is the characteristic optic neuropathy, which is the correct answer, of course, because as you all know, the increased pressure per se is not a cornerstone in the definition of glaucoma, because we do have the normal tension glaucoma. Progression is part of the definition, but it is not the cornerstone, because sometimes we have non-progressive cases where the pressure settles down and the case ceases to progress. And the visual field defect is also part of the glaucoma definition, but sometimes we have what we call pre-perimetric glaucoma. So this is the answer, correct. Glaucoma is a group of disorders sharing a characteristic optic neuropathy, which is progressive most of the time, and derives from various risk factors that include but are not limited to the increase in the IOP. Now, I like to think about glaucoma as a matter of structure and function, and to trace the structure back. The main pathology is usually the what we call the outflow or the trabecular meshwork. So it's a trabeculopathy leading to an optic neuropathy. Even in the normal tension glaucoma subtype, you do have a trabeculopathy because the pressure for that patient, for that normal tension glaucoma patient, is above what the nerve can tolerate, and usually it's in the high teens, low 20s, but still in the statistically normal intraocular pressure range. So this is the trabeculopathy leading to the optic neuropathy. Again, if we divide them to structure and function, even the trabecular meshwork has a structure and function, and we can assess that by clinical means and some tests and devices. But what we are concerned about in the clinical practice actually is the optic nerve head part, the structure of the optic nerve head, which we call the GON or the glaucomatous optic neuropathy, and the functional part, which we also usually measure with the perimetry. This is the glaucomatous optic neuropathy part, the structural part, which we all know. On the left here, we have the normal optic nerve head, and then we have moderate glaucoma, and at the end, on the right side, we have the advanced or subtotal cupping or end-stage glaucoma. So usually, when we divide structure and function, structure is the optic nerve head clinically or with disc photos, and then we have the function part, which is usually the visual field. This is what we are talking about tonight. Glaucomatous optic neuropathy, the famous Forge study by Liebman and colleagues from New York. We have the 5 R rules. You should observe the scleral ring to identify the limits of the optic disc and its size, and then look at the size of the rim, the neuroretinal rim, which is very important, and then the retinal nerve fiber layer. And this is all clinical, of course, but now we have the OCT to measure the thickness of the retinal nerve fiber layer, and then the region of the parapapillary atrophy, and then the retinal and optic disc hemorrhages, or what we call the trans hemorrhages. So this is the structure part. What about the functional part? As you can see here, the visual field, and this is the visual field on the right side. This is the force 2 part or the function part. You should be able to identify the right test. This is this your patient? Is this reliable? The reliability indices, and you should review the probability plots in the lower part here of the total deviation and pattern deviation probability indices, and then the RNFL pattern of loss. So it should be a glaucomatous pattern of loss, a nasal step like in this one, or an arcuate scotoma or a sided scotoma in the beiram area or the geram area, and you should reaffirm the diagnosis. So always compare to the clinical picture. But the idea here is to match the functional part with the structural part. So not only if you have abnormal structure plus abnormal function, then you diagnose glaucoma. No, you have to have a matching, anatomical matching of visual field and the optic nerve head. And this is in glaucoma and also in neuro-ophthalmology. You should have a matching between them. But the most common mistakes are done in glaucoma, where there is abnormal visual field, abnormal OCT or optic nerve head, and then you come up with an immature diagnosis, I would call it, of glaucoma. So as we all know, the structure and function do not go hand in hand. They have different speeds or different rates of progression or deterioration. The visual field might be the latest. The disc is before that, and the RNFL, especially with the OCT we are talking about, is the earliest, and maybe the ganglion cell complex is the earliest. As you can see here in the European Glaucoma Society guidelines, the 4th edition, when they talk about structure function, they start with the visual field. And this is not the way I like to start with. I like to start with the structure, because you examine the patient and then go to the visual field. But sometimes what we face in our clinic, especially when we have referred patients, you get sent the visual field, and you get asked, Dr. Muhammad, is this glaucoma? And so you look at the visual field and assess if it's reliable or not. Is it borderline? Is it clearly abnormal? So if it's clearly abnormal, and then you go back to ask your referring colleague, is this structurally abnormal? Do you have an optic nerve head cupping or local or diffuse damage of characteristic of glaucoma? And if the answer is yes, then there is a positive diagnosis, but you should make sure that it matches. So if I have an optic nerve head lesion in the temporal area, and the visual field has something like an increased size of the blind spot or enlarged blind spot, then this is not a matching. Anatomy. In the old days, we used to diagnose glaucoma with progression. So when they used the Goldman perimeters, we used to wait for the structure and function to deteriorate or progress, and then say this is glaucoma. But now when we have the very sensitive tools like the standard automated perimetry and the OCT, then whenever you have a structure function match that is a correct anatomical match, then you diagnose glaucoma. So I'd like to go from the beginning and classify the thing from the beginning. Then if I start with the optic nerve head, glaucoma suspect, as you know, is either glaucoma suspect by visual field or optic nerve head or intraocular pressure if it's ocular hypertension or any IOP above 21 or above. But let's stick to the optic nerve head suspicion, a glaucoma suspect in terms of cupping. So if the visual field is normal, if it's full on the left side, then it's either preperimetric glaucoma, especially if you saw the RNFL thinning on the OCT, or it's a physiologic cup. These are the two differential diagnoses which come out with normal visual field. But if you have a scotoma and the scotoma is reliable, the visual field test is reliable, then it's either a matching anatomical to structural part, structure function correlation, then this is GON. But if it's not matching, if it's something like bitemporal hemianopia or homonymous hemianopia or pie in the sky or something like that, then you start thinking neurology, neuro-ophthalmology, CNS. And again, if you have something like superiotemporal or bisuperiortemporal anopias and the disc is tilted or the vessels are anomalous, then you might have a glaucoma suspicion with a suspicious visual field, but they don't match as glaucoma. They only match as anomalous, and you keep the label as glaucoma suspicion and you continue the follow-up. So let's start with case number 1. So I will start with the structure, and I would like to see how the function goes with this. So if you look at this optic nerve, it's a cupped optic nerve, I would say 0.8 cup to disc ratio. If you look at the OCT, it's inferotemporal, temporal, but mostly inferotemporal. So where do we expect the function to be lost? This is the question. Poll number 2, please. Can we see the answers, please? So 75% of the audience would say that the defect inferotemporal in the optic nerve goes superior-nasal, which is the classical teaching that we all know.
Are we having a technical problem, Tariq? Muhammad, we don't hear you. طيب meanwhile عبين ما while Dr. Muhammad is reconnecting, please don't hesitate to write your questions in the chat. You can go to the chat box and write your question. Now, if you want to ask questions, you can go to the participants. Where is the raise hand? And raise your hand. And after we conclude the presentation, we can go to discussion. But we are still waiting for Muhammad to reconnect. This happens every now and then. Muhammad, are you with us now? Muhammad, please unmute yourself.
Yes, hello, sorry for the
Okay.
technicality.
Okay.
Was I only out or everybody was out of the meeting?
You are the only one who was out.
Okay. So we're good to go, right?
Now it's okay.
Okay. So the actual visual field defect is the superior-nasal. Let me go back to the
Share your screen.
slideshow. Yes. So this is the Garaway heat map from Moorfield. So as you look at the areas, the temporal one, inferotemporal, the red one goes to the superior-nasal, the blue one goes to the infero-nasal in the visual field, because the temporal goes nasal. But the temporal goes nasal and central. But if you look at the yellow and the green, they go corresponding but peripheral. So this is the idea. This is very important in terms of the 24-2 versus 10-2 visual field. Now, the very temporal goes to the very central, goes directly to the area of the 10-2, and we can see that here. So let's start with the same patient. Let's continue with the same patient. So as we said, it will go superior-nasal, central, and this is very obvious in the 10-2. So as you can see here, the 10-2 and the 24-2, the idea is the 10-2 is in the green area, is more stratified, more points. So it's like 68 points versus something like 54 points in the 24-2. So it's more central, more stratified, and is very, very sensitive for ganglion cell complex changes, very sensitive for early RNFL changes. Case number 2. This is superior-temporal in the OCT. Unfortunately, we don't have the optic nerve, but this is superior-temporal. So where do you expect the defect to go? Poll number 3, please. Can we see the answers, please? So again, infero-nasal, 60% of the audience, 56% of the audience is infero-nasal, but the actual answer is the infero-nasal central, because by the same map of Garaway here, we should go to the infero-nasal central. That's why if you look at this one more time, the blue area, the superior-temporal, would go infero-nasal central, not the periphery, not the green one. And this is what we see here in the case. And the 24-2 is not obvious, but if we do the 10-2 on the left side, you can see it's infero-nasal central and not peripheral. Case number 3, we have a classical inferotemporal thinning of the RNFL in the right eye, as you can see here. So where do you expect the visual field defect to be? Let's see the poll right now also, and I think you got the point. Poll number 4, please. So can we see the answer? Exactly. So now you got the point. So we have a map done by Garrow, Heath, and Moorfield. It's like a retrospective study. They studied all the visual fields, the 24-2 that is, versus the optic nerve head RNFL on the OCT, and they came up with the map. It's a crude map, but it's a very nice one to do clinically in the office, in the clinic. But again, as we said, we have the more sensitive ganglion cell complex, the more sensitive machinery coming out. That's why we have to implement those more accurately in our practice. So let's skip this. So this is superior-nasal central. As you can see here from the Garrow heat maps, you should go with superior-nasal. It's exactly where we expected in the superior-nasal area in the right eye. And if we do the 10-2, it's a classical coma, what we call a coma. And this one, I'm going to show you how it matches with the ganglion cell complex also. So to review a little bit about how they do the matching, actually this work by Hood in 2011 started a whole branch of a whole new branch of glaucoma diagnosis, which is called the structure function correlation on OCT, and they compared the macular scans, the peripapillary scans, and the ganglion cell complex. So let's look at this. They took the 10-2 on the left side, and they do a little bit of displacement because there is a ganglion cell displacement in the fovea. You don't have cells packed there, so you should do the displacement. And they overlaid it on the macular RNFL scan. As you can see here on the left side, you have the displaced 10-2, and if you overlay the donut-shaped retina ganglion cell complex, it's like an exact match for this piece. And why is that? Because this 10-2 is flipped on the horizontal meridian, or flipped vertically, if you would say. And this is the whole methodology of Hood, starting in 2011 until we reached what we call the Hood report. So as you can see in the first line, 24-2, 10-2, then we have the macular retinal ganglion cell complex, and then you have the macular RNFL alone, and then you have the peripapillary RNFL, and all these 10-2s are flipped over the horizontal or flipped vertically like a mirror image, and they always match the missing part of the donut. If you look at the first column on the left, the colored one, you have a missing part of the donut here, you have a missing part of the donut here, and if you complete it with the probability plots of the 10-2, you have an exact match. So what about our patient here, the supernasal? If you look at the ganglion cell complex of the right eye on the left side of the slide, you can see that there is like an inferior arcuate loss of the ganglion cell. Let's go back to the visual field. So this is the coma. This is the coma. And as you can notice in the coma, there is like a what we call a vulnerability, low vulnerability area here. 2 degrees of no damage in the supernasal quadrant. So it is in the supernasal, but there is a small area of low vulnerability. We call it the low vulnerability zone in the visual field. So if I flip it over the horizontal meridian or vertically, look how it compares to the ganglion cell when they are displayed side by side. The same low vulnerability area here in the ganglion cell complex, it's the same as in the 10-2. So this is what we call matching of the 10-2 with ganglion cell complex. So anything that is outside this matching is not considered glaucoma on diagnosis, especially for the early case. But if it matches the anatomy, then this is our ruler, this is our guide. Anything that defies this should be suspected and only put label of glaucoma suspect and not glaucoma diagnosis. I'm gonna end with case number 4. It's a peculiar case actually. It's between neuro-ophthalmology and glaucoma. If you look at the left eye on the right side of the OCT, clearly it shows pixels in the area of the temporal RNFL and a little bit superiorly, but mainly if you look at the color maps, it's in the red area and the temporal area. So this patient came complaining of blaring of vision, episodic in the left eye, something with headache similar to migraine or cluster headache, but again, the pressure was something around 21, 20. We suspected normal tension glaucoma, so we did the OCT and we did multiple visual fields. And if you can see here, the visual field on the right side, there is a little bit of a nasal step. So maybe this is early glaucoma. We don't know yet. What I did for her is the RNFL scan on the TopCon machine, which is the Hood report. And of course, since 2011, Hood himself developed this report. So he superimposed the 24-2, as you can see here, with the 10-2, with the scans flipped over the horizontal meridian or vertically, so that you can easily predict your visual field defect. So this is an OCT machine that can predict the visual field damage, but the predictability is not 100%. So it only tells you if there would be a scotoma, it should be in this area here in the 10-2 or in the 24-2. But if you don't see the defect, then maybe it's still pre-perimetric. If you see the defect and it matches, then you have a high index of suspicion that this is actually glaucoma. If there is a scotoma but does not follow the rule or the Hood report, then it's most of the cases, most of the times, it's not glaucoma. So let's look at the right eye here. As you can see, it predicted that the visual field would become central inferior in the 10-2. But look at the ganglion cell scan down below that Hood report. Look at that area here. You still have good ganglion cell complex in the very center of the right eye. And if we go back to the 24-2, it's only a nasal step in the left eye, in the right eye, excuse me. So is this matching? I don't think it's matching with what the Hood report predicted. What about the left eye? The left eye is predicting a very dense scotoma in the center, superiorly in the 10-2. And if you look at the ganglion cell complex, the empty area in the center is very restricted compared to with the right eye. That's why I would say the suspicion is higher in the left eye, which is the eye that is complaining. So let's have a look at what we got from the 10-2. So actually the 10-2 in the right eye came up with scattered points, maybe in the nasal area, but not matching the Hood report. But if you look at the left eye on the left side of the page, the slide, you can see that it's a very dense scotoma in the center. Now, does this define glaucoma, or can we say this is 100% glaucoma? For me, as it matches the anatomy, I would say yes, but we still have a differential diagnosis of central CNS scotoma. Sometimes this happens with migraine. You can still have those scotomas, so this should be followed up. But as you can see, the hood report is a very, very useful tool in hand to let's say predict the visual field. So if you don't remember the Garaway heat maps, you have the hood report, and it's easy to obtain if you have the OCT from TopCon. But also now they are starting to do multiple reports, like the Zeiss have their own platform, the OptiView have their own platform to combine visual fields and OCT. And lastly, I would end with this the NFAS, also from TopCon. The NFAS scan, this is from Japan. They also overlaid or combined the 10-2 visual field with the OCT RNFL from the macular scan, the NFAS. And as you can see, they did the same displacement as Hood did, and then they flipped it over the vertical or vertically over the horizontal meridian. And then on the right side, D of that figure is the actual total deviation and pattern deviation plot of this patient. And it's almost an exact match, except for those 4 points in the inferotemporal. I would say it's almost an exact match. So the predictability of these anatomical locations is very high, and this is based on hundreds and hundreds of patients. So we now actually know where every bundle of fibers goes in the visual field, and where it goes from that visual field to the optic nerve and vice versa. Thank you very much.
Excellent presentation, Muhammad, as usual. Now we open the door for questions. I will read some questions from the chat from Dr. Arij. So that means OCT after visual field?
What's the question, please?
So that means OCT after visual field?
Actually, no. The pre-perimetric glaucoma OCT usually is more sensitive than visual field, but sometimes with the 10-2, I like to call it subperimetric. So if you are comparing 24-2 to the OCT, yes, OCT will be first. But if you go to 10-2, because it's more correlated to the ganglion cell complex, maybe the OCT is after, or at least at the same time of the 10-2. But again, most of the cases we see with 10-2 scotomas, the OCT is before that. So still, I would answer OCT most of the time is before visual field. It develops changes of glaucoma before visual field.
So another questions, if visual field is normal with big disc, that's the question. What do you do?
If visual field is normal with a large optic nerve head, if the cup is also large, so
big
a large
disc, big disc, yeah.
Yeah, if a large disc with a large cup, I would only measure the RNFL by the OCT. So if the OCT tells you there is no RNFL defect for that disc, I would only label him as a glaucoma suspect and continue follow up. So this visual field usually is really normal. But if the disc is large and the cup is large and the RNFL comes with RNFL defects, especially if it's not a myopic disc, because sometimes with myopia, high myopia, you have artifacts. If it's not high myopia and you believe this RNFL defect is characteristic, then it's probably pre-perimetric glaucoma, and maybe you would start medication for that, even before visual field change.
Another question from Ali Majid. First sensitive functional test.
So the first sensitive functional test, as you could see, we like to combine tests. We don't like a single test for glaucoma. So if you tell me I have a cup to disc ratio of 0.6 with an inferotemporal notch, and the visual field came with a nasal step, but the OCT is still showing yellow borderline probability and most of it is green, I would incline to my clinical picture. So if the pressure is like 26 or 25 or 30, then for me this is glaucoma, even before the OCT test. But most of the time, no, the OCT would be sensitive. So if you are asking me which is the most sensitive test, I would say if it's a single answer, I would say OCT, but usually the right answer is not a single answer. The right answer is a combination of structure and function, which was the title of our webinar. So a combined clinical picture with a visual field, the right visual field. I would say that is the highly sensitive function.
From Riyad Ahmed, in suspected cases, any role of cases like MD-PSD, CPSD to help in diagnosis?
Usually we don't rely on the numbers for diagnosis. We rely on them for follow-up to detect the progression if the numbers increase. In research, we like to rely on numbers, but in clinical we can get help from the numbers, but what we look at is the actual probability plots, the total deviation and the pattern deviation. So I'm looking for an arcuate scotoma, a sidal scotoma, a nasal step, a temporal wedge, something like that, but I don't look at the numbers. When do the numbers help? If you are looking at a visual feed, comparing it to a more recent visual feed and saying, has this progressed? And then you can rely on the numbers, but not for the diagnosis to start with. They do have normal and abnormal cut points, with the pattern standard deviation being in the plus, or the positive side, and the mean deviation being in the negative. But we do not rely on those for diagnosis.
Dr. Hiba Rihani asked, in cases of myopic tilted disc, what are the best tips to make sure changes in OCT are glaucomatous rather than from the tilt?
This is a very difficult question to answer. It's a very good question, but we still don't have any normative data for the highly myopic patients. A couple of papers came down from South Korea talking about how to get normative data for those. But usually, what we do in our practice is that you try to get the closest answer to reality. So what we do, if the patient has like -10, if I can put a contact lens before the OCT test, it's better than having him being compensated by the machine, because the machine has a limit, something around -8. So if he has something like -6 or -8, maybe it goes well. But if it's like -9, -10, then I would recommend doing a contact lens, and then again making sure it's not cyclotorting, because that would change the results. If it's really tilted and the temporal RNFL is covered behind the optic nerve, then even if you get a decrease in the RNFL there, I wouldn't say that is glaucoma until I have, let's say, progression. So progression in terms of visual field, progression in terms of RNFL. But if it's only temporal thinning with corresponding scotoma, maybe all that is just because of the tilting. So we don't have an answer yet. We hope to have soon, but I would recommend doing the contact lens for correction, and then also depending on your clinical judgment. So disc photos, progression, changes of the vessel location with time, especially with the stereo disc photos, depending on the beta zone, if it's enlarging in size with time, that would be good. But if you depend only on the RNFL in one reading, it might be only the myopic effect and not the glaucoma effect.
A question from Dr. Ibrahim Shhade. Based on the development of OCTs, do you think we can reach a day to replace the subjective visual field with objective OCTs?
That's a good area to think about. Now, depending if you remember what we said about the Hood report and the reports from Japan with the NFAS technology, I think it will come very slowly towards that goal, but it's not impossible. The problem is that the neural circuits of the brain, the neural circuits of the visual system as a whole, they are very highly adaptive. So even if you have a prediction that you have a scotoma, a lot of times you don't have a scotoma. That's why Hood mentioned that you should not rely on this to replace a visual field, but only to predict the visual field. So you do the OCT, you predict the visual field. If the visual field you actually do matches the one that Hood predicts, then you are okay. But to replace them, it is not a good idea, because most of the time it will match, but sometimes, a lot of times, you will have a defect in the OCT, a defect in the clinical picture that is similar to glaucoma, but the visual field would come normal or less than the scotoma predicted, and that is because of the neural adaptation. The fibers can compensate. Near fibers would supply the areas that you think will get scotomas, and this has been proven by adaptive optics studies, where you can see a very small fiber that is lost in the map, but the visual field still function in that area. So the visual field, again, if we go to the question, which is the more sensitive, it has to be a combination of both all of the time. So I don't think there will come a time within the next 10 years that we don't use visual field. But if something like a breakthrough happens, maybe that would be very nice. But till now, I would rely on both the OCT and visual.
Good. Another question from Dr. Arij, borderline OCT and intact visual field. So repeat exam after 6 months or 1 year?
This also depends on the IOP, the whole clinical picture. So if there's a low index, I call them the low risk, let's say ocular hypertension, maybe after 6 months. And if after 6 months the OCT shows no changes, I will expand that to 1 year. But if the OCT after 6 months comes out with a little bit of defect in the temporal area, inferotemporal area, so you continue with the 6 months. Anything less than 6 months in OCT for glaucoma is of no high value, because the OCT and glaucoma are slow diseases. Glaucoma is a slow disease. So if you repeat OCT less than 6 months, it wouldn't change. The visual field, on the other hand, is a dynamic thing. It's a functional thing. Sometimes you have sick cells, sick retinal ganglion cells that might lose function but not get apoptosis, and then you can see some changes or what we call a fluctuation. So it's a good thing to have less than 6 months. But for the OCT, I think if it's a low risk, no changes, do it after 6 months. If after 6 months it's normal or no changes, then do it after 1 year, and so on.
A question from Dr. Muhammad, a glaucoma surgeon. Case 4 is straightforward normal tension glaucoma. What do you think? How can you differentiate it by visual field?
Now, the normal tension glaucoma, usually the visual field defect is closer to the center. So maybe the 10-2 is better in looking at it. So parafoveal scotomas closer to the center, deeper and denser. These are the usual types. And if you look at the 10-2, usually they have what we call the coma, as I showed you in case number 4. This is the usual picture of normal tension glaucoma in visual field. So if you do 10-24-2, you might have the paracentral scotoma if it's large enough, but the 10-2 is definitely more sensitive.
Good. I don't see any other questions. Let me see. Any more questions from the attendees?
I have a question from Dr. Ghadir Al-Humaymat. Would you recommend 10-2 as an essential part of routine examination and follow-up? Absolutely, yes. This is even become part of the guidelines. It's part of the medical legal also. So any patient with newly diagnosed glaucoma, go for 10-2. Probably not the first choice. Do a 10-24-2, and then on the follow-up, maybe 3 months later, get the 10-2. Also in the advanced glaucoma, I like to get a 10-2 for the sake of low vision aids, functionality. If we are going to surgery, I like to see that there is no split fixation. This all depends on the 10-2. So anybody going for surgery or even laser, please don't go to procedures without 10-2. 10-2 has become an essential part of routine examination and follow-up. Yes.
Okay, any other questions? I don't have any questions in my screen.
I have from Ali Majid also, media opacity, especially central, which is more sensitive, 10-2 or 24-2, which is more reliable. Let's say cataract or lens opacity. Usually the 10-2 is less affected by media opacity, but when it's dense, like when the vision is less than 0.6 from that cataract, I think the 10-2 and the 24-2 would give you a lot of scotoma in the center. So you do it, you don't rely on it, you repeat it after you remove the cataract, and then you continue follow up on the new on the new baseline.
Another question from Dr. Angio adds to you as a glaucoma specialist.
The OCT angio, that's a good question. The OCT angio has become a very interesting tool in studying diseases, whether glaucoma or retina. We do have multiple studies on glaucoma showing that the peripapillary area blood supply is being depleted, but we don't have objective measures yet. We don't have like this is progressing. We have normal and abnormal cut points, but we don't have this is mild, moderate, or severe OCT angio defect. So till now we don't have that that kind of tool. I don't rely on it routinely in my practice, but I think once it becomes a part of the follow-up strategy, because the most important thing about glaucoma is the follow-up for the patients after you make the diagnosis. So once they have the stratification or the staging, like mild, moderate, severe, I think it would be part of the guidelines. But till now, we don't have guidelines for implementing OCT angio in the diagnosis or follow-up of glaucoma patients.
Another question from Dr. H. What about blue-yellow visual field?
Now, the blue-yellow visual field is a very good tool, similar to the FDT, the frequency doubling technology. So you have the FDT and the blue-yellow or the SWAP, short wavelength automated perimetry. They are very widely used in research, or I would say probably in the early 2000s, late 90s, they were very much used in research before we had the good OCT. So what we found from the studies is that early changes in blue-yellow visual fields in terms of glaucoma are the ones you see later when you have the 24-2 changes. So if you are talking about pre-perimetric glaucoma, then maybe the blue-yellow shows you those early changes that the 24-2 cannot get. But nowadays, the 10-2 is much more important than the blue-yellow because it correlates directly with the anatomy of the ganglion cell complex. So I don't use the blue-yellow routinely in my practice.
Another question from Dr. Adif. Which field test should be done in a neurological problem?
I think that's part of tomorrow lecture, but I think Dr. Ibrahim would agree that 24-2 is definitely number one for neurological, and the 10-2 also, and the ganglion cell scans are now becoming also part of the pre-geniculate, let's call them pre-geniculate lesions of the neurological pathway, the visual system, so the visual pathway. So
Right,
I think 24-2.
I totally agree. Actually, we would like to expand the visual field as a neuro-ophthalmologist, but whenever we expand the field, for example, if we go to 30-2, we get more artifacts. I think 24-2 is the standard automated visual field even for a neuro-ophthalmology. I think we're almost done. So by this, we conclude. Just a reminder that we will start tomorrow sharp at 9:30. Our talk will be about cases in neuro-ophthalmology. And next week, inshallah, we have another 1 or 2 webinars. So thank you all for your attendance, and have a good night. Thank you.
Thank you very much.